And now it's time to move to our next speaker, Antonio. I think Antonio is going to speak about very important topic, how to build an atrial fibrillation clinic. So we are waiting for you, Antonio. You are muted, Antonio. So can you unmute yourself, please?
Unmute. Can you hear me now?
Yes, please.
Okay. I would like, first of all, to... so can you see my video?
Not yet.
Not yet. Wait. Share. Gonna... to share the video. Okay, share screen here.
So now it's clear. So can you move to full screen, please?
Yes. Just a moment. Okay. Can you see me clearly now?
Yes.
Yes. Okay, I would like, first of all, to thank you, all the organizers of a very interesting and interactive meeting, Cardio Go 2021. I'm Antonio Sorgente. I'm an associate editor of JACC Case Reports. I have the pleasure to work side by side with Julia, and it's very hard to make an interesting presentation after the nice and really performing images she showed. But I will try actually to give an idea on how to build an atrial fibrillation clinic and how to actually, I would like to share my own direct experience. So I want to just show you the agenda. So we're going to go through a clinical case. We're going to actually speak very briefly about, what are the general considerations that we have to do when we speak about atrial fibrillation. We also will look specifically to the part of the guidelines that actually are important and which actually prompted the necessity, in my view, to create an atrial fibrillation clinic. I'm going to give a very small wrap up on the literature supporting the creation of an atrial fibrillation clinic, and I will actually show you a little bit what were the main steps I went through building up the clinic in my center. So the clinical case is a simple 69 years old male patient with a history of mitral valve annuloplasty and persistent atrial fibrillation, who underwent more or less 2 years before an electrical cardioversion. He presented to my clinic in sinus rhythm. His cardiovascular risk factors were impaired fasting glycemia, hypercholesterolemia, and hyperuricemia. Other comorbidities were mainly due to benign prostatic hypertrophy. His medication were flecainide, nebivolol, dabigatran, and terazosin. And the main symptoms actually reported when he came in clinic was fatigue, near class, which was actually between 2 and 3, probably more on the 2 side. He was not very sportive, not very active, and he actually was referring ERA 2 symptoms, so not very symptomatic on the side of atrial fibrillation. His BMI was 26.7 and the blood pressure in clinic was 110/70. This is the electrocardiogram. The time actually presented to the clinic. You can see the patient was in sinus rhythm, and there was nothing really other than probably a small prolongation of the QT interval. We perform an echocardiogram. Unfortunately, I cannot share these images because it's an echo that was in an old server. But I mean, what you can see and appreciate from the numbers is that the patient had a very dilated left atrium with an anteroposterior diameter of 56 millimeters. He underwent Holter, and on the Holter, we confirmed the presence of a stable sinus rhythm. But unfortunately, during the 24 hours recording, we documented the multiple sinus pauses. The longest of one was of 13 seconds. In particular, all the pauses were during the night and from 2 o'clock to 3 o'clock in the afternoon. So given this initial clinical picture, I want to just provide a clinical quiz, and I'm going to give you the answer, what I actually did at the end. So I proposed to stop flecainide and nebivolol. I proposed as second choice to stop flecainide and nebivolol and to proceed for a pacemaker implantation. I can offer an AF ablation to these patients. And of course, performing some non-invasive tests like a blood test or a sleep test. I will give you the answer at the end of the presentation. In the meantime, let's actually give some details about atrial fibrillation. As you know, atrial fibrillation is the most common cardiac arrhythmia, affecting 1–2% of the general population. And this percentage rises to 10% or 15% in over 80 years old. Atrial fibrillation is independently associated with a significant increase in all-cause mortality, more than twofold in women and 1.5-fold increase in men, regardless of the underlying age. And also, as you know very well, AF is a significant cause of hospital admission and morbidity. In fact, in the last years, we can say that there has been a steep increase in hospitalization linked to atrial fibrillation. It has been called the rising tide, and very recently AF hospitalization have surpassed the ones related to heart failure. And many times heart failure and atrial fibrillation are occurring together. So given this preamble, we can say that, of course, atrial fibrillation represents a significant financial burden for every healthcare system. But also, it's very important to understand that atrial fibrillation is a chronic condition. And there has been a difficulty to convince cardiologists and cardiac electrophysiologists about this statement. And in fact, many efforts should be done in the future to change their mindset, in particular of cardiac electrophysiologists. Because cardiac electrophysiologists, usually, I'm a cardiac electrophysiologist, are actually thinking at atrial fibrillation in an arrhythmic perspective. So as you well known, this is a very well-known picture in which actually you can see that atrial fibrillation has usually its origin in triggers that are mainly located in the pulmonary veins. And after, dilation of the left atrium and creation of fibrosis, specifically in the left atrium, but also in the right atrium, you can develop a substrate that makes the atrial fibrillation more persistent. But many times we need to think of atrial fibrillation like, the fever for internists. So it's actually our fever in the field of cardiology, I would say. And you have to put inside, the atrial fibrillation a lot of thoughts. You need to think that, of course, aging is one of the first causes of atrial fibrillation, together with the ethnicity, to the male sex, of course, and genetics. And there are, of course, a long list of risk factors for atrial fibrillation. I usually like to differentiate these risk factors in cardiological and extracardiological risk factors. As cardiologists, we can actually take care very well of the cardiological risk factors, but as you can see, the list of extracardiac causes or risk factors of atrial fibrillation is even longer and includes, as you well know, dystherodism, chronic kidney disease, obesity, sleep apnea syndrome, alcohol intake, gastroesophageal reflux, and so on, and of course the genetical background. And if you can think as a single cardiologist to take care of the cardiological risk factors, I think it's more difficult for a single cardiologist to take care of the extracardiac risk factor. And this is the reason why I think it's important to change a little bit the shift in the treatment of atrial fibrillation. And this has been recommended by the most recent guidelines published by the European Society of Cardiologists. You see here the ABC pathway. So the ABC stands for A, anticoagulation. When you encounter a patient with atrial fibrillation, you need, of course, to identify the risk of embolic stroke, of embolic events with a very well-known CHA2DS2-VASc score. You need to assess bleeding risk, address modifiable bleeding risk factors, and of course, choose the oral anticoagulation. This is something that is well done by all the cardiologists. The cardiologists can also do very well, symptom control, so they can actually decide easily which is the best strategy for patients with atrial fibrillation. Shall we actually decide for a rhythm control, or shall we actually go for rate control? Of course, there are many, as you all well know, many clinical and diagnostic tools that can help, to direct the therapy to decide whether rate or rhythm control is the best choice for a patient. But the C point, so the assessment of comorbidities, the cardiovascular risk factor management, this is actually very well done by other entity, by other specialties, and less by cardiologists. That's the reason why, given the fact that there is a class 1 indication in identification and management of risk factors and concomitant disease in patients with atrial fibrillation, it's very important that an atrial fibrillation clinic would be better in supporting cardiologists taking care of this aspect. What is the literature supporting the creation of an AF clinic? There is a vast amount of small studies. I would say the group that is very active in promoting the creation of an atrial fibrillation clinic is in Maastricht and in Australia. And the group in Australia is actually led by Prashant and Sanders. And they actually pulled the efforts together. They made interesting trials demonstrating, with the aim on demonstrating how an atrial fibrillation clinic can really impact on the quality of life, but above all on the mortality of patients with atrial fibrillation. And I want just to cite this small but very interesting study. It's a post hoc analysis of a previously randomized clinical trial in which actually the patients were recruited in a randomized fashion to be treated as usually, so with the usual care, patient of course with atrial fibrillation, rather than being put under the observation, under the umbrella of an atrial fibrillation clinic. So the authors actually selected the patient who died in the two arms. So if I remember well, there are 42 deaths in the two arms. And you can see here with this very clear Kaplan-Meier how actually the cumulative all-cause mortality that you see here on the left was clearly higher, significantly higher in the patient who underwent unusual care compared to patients who actually were followed in the atrial fibrillation clinic. The differences stand in particular in the fact that the patients that were followed in the atrial fibrillation clinic underwent more often to thyroid function testing, as you can see. So there was no difference in the number of echocardiograms done in the two arms. And above all, there was a difference in the appropriateness of oral anticoagulation prescribed according to the stroke risks. And actually, the table 3 on the bottom of the slide can actually confirm this impression, because there was a significant difference in the number of vascular non-cardiac events, which actually were mainly embolic stroke and pulmonary embolism. So the patient who underwent usual care actually underwent more often, got more often a pulmonary embolism and an ischemic stroke. And this actually accounted mainly for the difference in mortality. So I would say the atrial fibrillation clinic can actually give a difference, especially in the way that patients are followed, especially in putting the patient under a more compliance against anticoagulation. The second study that actually has been published by the same group is a systematic review and meta-analysis, in which their study was actually put aside to another study published by Stewart et al. And the meta-analysis confirmed that the impact of an integrated care on all-cause mortalities was significant. Patient treated in the atrial fibrillation clinic had a mortality which was 49% less than patient undergoing usual care. So let's give some hints or advices on how to build an atrial fibrillation clinic. Of course, you need to engage all your, I'm an electrophysiologist, but I think an atrial fibrillation clinic can be led also by a general cardiologist. So the main thing is the motivation to do that. And when actually you're building an atrial fibrillation clinic, you know that the atrial fibrillation clinic will be the center of sort of a little universe in which you can put, every single specialty. I would say specifically internist, geriatrician, endocrinologist, neurologist, pulmonologist, gastroenterologist, and nephrologist. But I would say the most important thing, it's to create a channel with the emergency department in order to capture the patient when they arrive to the hospital with a diagnosis of atrial fibrillation. And I would recommend also to have an interaction, very strict interaction with the sleep clinic. That's actually the key point because as all of you know, atrial fibrillation and sleep apnea are very good friends. And it's important also to have good relationship with general practitioners and heart failure clinic. But the first question that I usually had to answer is to general cardiologists is, are you stealing my patients with atrial fibrillation? Because of course, atrial fibrillation is one of the main reasons why a patient consult a cardiologist. So every time I have to, give the same answer, no, I'm not stealing your patient. I think the atrial fibrillation clinic, as I showed, can actually help in providing the comorbidities and the clinical management that the general cardiologist all alone cannot provide. And I think that the key point in the creation of the atrial fibrillation clinic is actually the selection of a nurse or a coordinator. And so this is actually the most difficult part. Of course, you need to go through different kind of feelings inside the clinic to select someone. And so, first of all, you have to actually try to separate the jealousies among the nurses. But once you have actually selected who you think actually is the best candidate for this, you know that this candidate will serve as a primary contact for atrial fibrillation clinic and the other departments. We create standard operating procedures in order actually to give protocols on how to implement the care of atrial fibrillation. Of course, the nurse will be in the first, the first step for the education, and so we created some brochures that are, available in all the languages. I remember we created the same when we were working with Julia at Cleveland Clinic Abu Dhabi. And we actually have the clinic coordinator has to actually collaborate with all the hospital staff. We need, in particular, to integrate the inpatient outpatient care and the transition of patients from, the discharge or the emergency department to the outpatient department. And above all, I think one of the most important things is that the clinical coordinator should be able also to perform a database collection and obviously create an abstraction of the data in order to get an idea of the morbidity and the mortality data of your atrial fibrillation clinic. And that's the reason we created a specific database, which actually is the database that is used routinely by our nurses to fill the history of the patient. So actually we capture all the possible interesting variables that goes from diagnosis, the cardiovascular diagnosis to non-cardiovascular diagnosis. And in particular, we gave also, and I show you the importance, a specific space to the treatment. Because, of course, if we want to improve the compliance, if we want to reduce the side effects related to medication, the list of medication should be very clear and should be very clear also to the patient. And that's the reason I think the second important figure when you actually build it up an atrial fibrillation clinic is the pharmacist. I think he or she has a fundamental role in the review of medication taken by the patient, which are, as you know, often very, very long. The pharmacist has to helping identifying the potential drug-drug interaction, give advice on dose adjustment according to the most recent blood test, and also give education, in particular, concentrating on the compliance of the patient and on the side effects, in particular bleeding, because I mean, this is the main reason actually we are following this patient, to avoid unnecessary bleeding, to avoid that the patient reach the major bleeding before time. And one important thing that I have to notice, I remember this story in which actually a patient of mine went through my consultation. I actually collected the number of medication he was taking, and the pharmacist came at the end telling me that this patient was taking twice the statin, and this is actually not very well understood by myself. So I think the pharmacist has an important role, and she will be very important in also helping leading this clinic. I think the figure of the dietitian is again central. Obesity, sleep apnea, atrial fibrillation are going all together, and so actually the dietitian as a central evaluation. I like to send my patients to the dietitian regardless of the body mass index, in particular to understand which is the burden of the alcohol intake. Here in the north of Europe is very, very high, as you can imagine. The other actually figures that are as well important, the IT specialist. Without a very motivated IT specialist, the creation of the database, which actually can collect in real time the data of our patients, was actually impossible. And actually this asked me a huge effort of coordination. But actually this is very important in order to get the information about our patient in almost a click. And also, I mean, a figure that we're going to introduce very soon in our clinic as psychologists, important is to provide AF quality of life questionnaires and the psychological support, especially in patients who are under stress or in case of excessive alcohol intake. I would say also that we actually are able nowadays to provide some ECG recording system to the patient. One of the most known, as you know, is Apple Watch, or the other one, it's again with FibriCheck is another web application that we can use to check if the patient is routinely in atrial fibrillation or in sinus rhythm. What about a little bit the duration of the visit? So actually, I saw that it's necessary a visit of 40 minutes to 1 hour when you speak about the first visit. In fact, this visit should be actually a mix of clinician and nurse led. During the first visit, we actually try to do all the tests, cardiovascular tests possible in order actually to give the initial picture of our patient. And afterwards, we like to get referral to dietitian, referral to the sleeping test, to the sleep clinic in case we suspect sleep apnea. And we have to consider 30 to 60 minutes in order to get also to the pharmacist the time to investigate the compliance and the list of medication by the patient. Other investigation, of course, are dependent on the clinical presentation. And if you want also AF quality of life questionnaires will be also important to understand which is the morbidity or quality of life of our patients. Follow-up visit, usually in my view, the first one should be done within a month from the first one to discuss the results of the test of the primary visit, and afterwards can be actually scheduled every 3 to 6 months according to the patients, according to the clinical scenario. Usually these visits, they should be led by the nurse. The clinician should not intervene routinely. And of course, the intervention of the clinician should be actually important if there is there are new symptoms, there is a need of doing intervention, there are new ECG signs, or there is a need of change of medication. So just to conclude and not to bore you more about this stuff, I would like to give you a little hint about the initial patient I presented. So what I did, I stopped flecainide and nebivolol. It was in sinus rhythm. And so I decided to perform blood test and a sleep test. And not surprisingly, this patient was not in a very good shape, speaking about results of the lab test. He was having a renal dysfunction. The glycate hemoglobin was fine, but he was having a very high cholesterol with LDL cholesterol of 192. And also, he was having a small alteration of the liver function, and it was in a huge hypothyroidism, probably because of a previous use of amiodarone. So what I did, I simply, refer the patient to the endocrinologist, to the nephrologist, and to the sleep clinic. And not surprisingly, if you remember well, the pauses were mainly during the night and during the afternoon when the patient was taking a little siesta. And so actually what was discovered that the patient had an index of apnea and hypopnea of 39. So he was diagnosed with a severe sleep apnea and was actually indicated for a CPAP. And just the last slide in which I show, the result of the last Holter. I left the patient without medication at the moment. The fatigue, of course, with the help of the CPAP and with the thyroid function that has been restored by the use of thyroxine after the endocrinologist consultation. So the patient symptoms are improved, and now, the patient can continue to be followed in our clinic. Thank you very much for your attention.
Okay, thanks so much, Antonio. I think this is very illustrative presentation. My question to you, actually, you elegantly showed up how to cooperate with different specialty like nephrologist, endocrinologist, and the problem here, the patient with atrial fibrillation, in my point of view, is a patient with multiple comorbidities, patient with heart failure, patient with valvular disease, patient with hypertension, ischemic patient, post-CABG patient, and all of those kind of diseases should be managed integrately by cardiologist. So in my point of view, the patient, if going to heart failure clinic, the medication should be modified according to his heart failure condition, then go to hypertension clinic, and so on. So what you are going to do in this situation? How to
so
make
no, this is a very important question. I thank you very much, because you probably hit the point. This was one of the first question from my colleagues. And so actually we set up an algorithm inside our clinic in order to select our patient in a best fashion. Of course, if there is heart failure, we have also an integrated heart failure clinic, and so actually the patient will go and will be followed by the heart failure clinic. No doubt about atrial fibrillation in that setting is probably is secondary, or is of course to be managed by an heart failure specialist as well. We can give advice, but of course that patient will be managed mainly by the heart failure clinic. As well, if there is an ischemic cardiomyopathy which is prevalent with the need of further intervention, I think, also this kind of patient should be stabilized before being sent to the atrial fibrillation clinic. But the fact, that I didn't show you is that we are actually trying to run our clinic in parallel with the usual care, because the point is not to forget our patient. Many times these patients are a little bit, let's say, abandoned. And so the problem is that many times, the cardiologist or whoever is following this patient has not enough time to correct all the comorbidities. So that's the reason why the clinic can be helpful in that setting.
Okay, thank you.
Antonio, Antonio, you have changed the mindset of our thinking, our critical thinking to AF patients, and I think, you made us think it as a comprehensive way of thinking for treating heart failure patients, AF patients. I'm asking, that there is different etiologies for development of AF in different countries all over the world. And probably in Egypt we have other causes like rheumatic heart. Maybe in your country you have hypertension as a main cause, thyrotoxicose, many causes. Do you think that the buildup of these clinics will be different from in different parts of the world?
So, also, I think this is a very nice question. I can report you my experience in Abu Dhabi that somehow is a little bit similar to the Egypt. Of course, there the epidemiologist of atrial fibrillation was completely different from what I face here in the north of Europe. I think the best thing is to actually run the clinic in a way that you cooperate with your colleagues, you define the epidemiology, and then you will find your way. It's not written in stones that you have to do specific things. These hints that I gave are actually following, the epidemiologies of the patients with atrial fibrillation who I encounter here. But I would say I remember the patients that I was encountering in Abu Dhabi, and they were much younger with more rheumatic heart disease, and actually was exactly what you are facing. So the main point is that you accept the atrial fibrillation many times, even if you can envision the cardiomyopathy is the main, let's say, trigger. Many times the other comorbidities are also contributing to that. So we need always to remember that, to find a lone atrial fibrillation, it's very, very difficult.
Recently, we have seen many cases with asymptomatic subclinical atrial fibrillation. Thanks to the new technology that allow us to record long hours of electrocardiogram. What is your policy in dealing with asymptomatic subclinical atrial fibrillation? The guidelines are not clear in this aspect.
That's something, as you said, I mean, it's not very clear. My personal attitude against asymptomatic atrial fibrillation is, of course, not to chase after the symptoms because the patient is asymptomatic. Of course, the first thing to do is to calculate which is the embolic risk factor of this patient and to provide anticoagulation if necessary. But of course, things can change in the future since we will be more and more monitored, and so I mean probably more data will actually come showing which is what is asymptomatic. There are already some data, as you have probably read, about the duration of atrial fibrillation that now is coming into also the game. It's not very clear if we need to consider, at the same fashion, if atrial fibrillation that lasts less or more than 6 minutes. That was the limit that was actually utilized in one of the studies with the pacemakers. But of course, I mean, the more will be monitored, the more information we're going to get about ourselves and our patients, and probably will be in the future more able to answer your question. At the moment, my feeling is that asymptomatic, as the guidelines recommended, should be not treated for symptoms. So if you actually want to treat, at the moment, an atrial fibrillation that is asymptomatic with an ablation, probably you are actually outside the recommended guidelines. But I know that this is a fluid field that can change rapidly in a steep fashion.
Wow. So thanks again for the elegant presentation. I'd like to ask about obstructive sleep apnea. You mentioned obstructive sleep apnea. So how would obstructive sleep apnea affect the outcome and management of atrial fibrillation? And for which patient you would order a sleep test for obstructive sleep apnea in patient with AF?
I mean, that's important to think that sleep apnea is, an endemic issue. Sometimes, we can actually use the stop bang score, to individuate those patients that are more at risk to have a high, there's the severe sleep apnea. But, in my experience, I would say my colleague in my hospital who directs the sleep clinic sometimes tells me that I give him too much work. I would say I don't really look anymore to the symptoms. I just think that a sleep apnea can be an easy trigger to individuate. So I think a sleep test done also with the actual technology that allows you to do the sleep test at home can be done and should be done more often than usual. Of course, there are some, let's say, issues about the costs, about how implement a sleep test in all patients with atrial fibrillation. But I think sleep tests should be used like an echocardiogram in patients with atrial fibrillation.
So
Dr.
last
Salah.
question from Dr. Sobhi.
Yes.
So Dr. Sobhi, this is our last question.
I'm just looking to your lecture and the questions. I wonder this. I think it's so difficult to make an AF clinic in our country in an easy way, because this, as you said, it is the fever of the cardiologist. So everybody knows that this patient is belonging to him. So he'll not send you the patient to you.
Yeah.
The EPS man differs from the clinician. The EPS man usually targeting the AF ablation. Most of the EPS looks the AF ablation and they believe 100% in this, which we don't see in every country. This is the results of AF ablation is 100. It should be repeated more than 50%. So it's so difficult, it's so expensive, it's not reimbursed. So if you come to truth, yes, I agree, because every disease in the heart now needs heart team. The structures, the coronary, the heart failure needs heart team. So in difficult cases, or in subclinical, as Dr. Abghani said, we need a group. This is called AF clinic group. To treat a special patients, we need AF, that's all. The subset of these patients, subclinical atrial fibrillation, persistent atrial fibrillation not responding to treatment, paroxysmal atrial fibrillation not responding, and should have a protocol in each hospital to be guidelines, because the EHRA differs from the European Society of Cardiology. You have a different guidelines. Myself, I'm doing my colleagues, for example, the East chapters in Egypt, I'm doing what's known as the LIFE program, higher education on the American College of Cardiology, treating all the cardiologists, what to be the main protocol, how to treat the patient in the case. So this is our job, not to specialize into a sophisticated AF clinics, which is so difficult. And I think the government of health will not reimburse this clinic unless it is spread with the clinicians. So to sum up, in my country, I'm not speaking about Belgium, so in my country, we need this atrial fibrillation clinic in some specialized centers for subsets of patients who need this clinic. Otherwise, it will not go. So start like this and maybe increasing.
I agree. I agree completely.
My final thoughts.
I agree completely with you. I mean, the meaning of atrial fibrillation, as you said, is to do a more integrated care of our patients, because many times, you send a patient to the electrophysiologist to do an ablation, and then you discover that the patient is in hypothyroidism, like the patient that I presented. Of course, I presented this case because it was really striking. I mean, probably another electrophysiologist, less clinical than myself, would have done an ablation or would have put a pacemaker in these patients. So that's something, of course. I understand. I know very well which are these difficulties, because it was not easy to convince all the colleagues around, and I'm still working on it, of course. But I mean, the thing is that the presence of an atrial fibrillation clinic can actually help to favor the integrated care.
Thank you so much, Antonio.
Thank you.
We really appreciate this important lecture.